afternoon, everyone, and welcome to Alberta Transplant Institute webinar series. We would like to acknowledge that University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nation, Métis, Inuits, and all the First People of Canada, whose presence continue to enrich our vibrant community. We would also like to thank you, Paladin, Estelas, and AstraZeneca for their support of the ATI seminar series. And with that, I would like to welcome Dr. James Len for agreeing to present in the seminar series today. Dr. James Len is an assistant professor jointly appointed to the Department of Pathology and Laboratory Medicine and the Division of Nephrology at University of British Columbia. He's the medical director of the Vancouver Immunology Laboratory and is an active transplant nephrologist at Vancouver General Hospital. Dr. Len is a member of many important organizations like CBS Willing to Cross Working Group, CBS National HLA Advisory Committee, CBS HLA Educational Committee, CBS Kidney Policy Implementation Committee, as well as for CST awards and grant commissions. He's a valued member of the Genome Canada Transplant Consortium and the UBC Research Excellence Cluster for Precision Medicine and Transplantation. Dr. Len is a very recognized leader in transplant immunology, both nationally and internationally. His research is mainly focused on two major areas, development and application of new technologies to improve donor-recipient immune compatibility, and to innovate new solutions for highly sensitized patients on the kidney waiting list. His research has been funded by numerous organizations like Kidney Foundation of Canada, UBC grants for catalyzing research clusters, as well as UBC Barbara Opperman grant. Dr. Len is the recipient of Vancouver Coastal Health Research Institute Mentored Clinical Scientist Award and Michael Smith Health Scholar Award. This has been a pleasure to introduce Dr. Len for today's talk, where he will be presenting on a novel cPRA metric to achieve equity in kidney allocation among candidate ABO blood groups. With that, I would like to ask Dr. Len to take over the forum.
It's a real pleasure for me to be here and to discuss the work. We've been working on this project for several years and very happy to report on the progress that we made, especially knowing that this metric could be implemented in the next few, probably over the next year or so, to help achieve equity in kidney transplantation. I want to acknowledge from the outset that this is the fruit of a lot of hard work from a lot of members in the HLA and transplant community, and I'll be acknowledging their work throughout this presentation as well. I don't have any relevant disclosures, but I will discuss data both from the United States and Canada, because I think as will become apparent throughout this talk, that both countries really do have a major influence on each other's allocation over the years, especially when it comes to the evolution of the cPRA metric. One of the fundamental principles of transplantation is that allocation must balance utility and equity. And one of the first things I learned when I was a trainee, oops, sorry, I'm just gonna move on here. And if you haven't read this paper before, this one I really like, a quote from Marx de Gaulle. And he said, "Those who do not know the past are destined to repeat it." He wrote this paper around the time when the new kidney allocation system came out around 2014. And this is really the what's referred to as the caste system in the literature, and the last major evolution of the kidney allocation system in the United States. And a lot of things went into that. And so I want to start the story from there. The allocation principles in the United States are spelled out by the 2000 OPTN final rule. So these are a set of regulatory principles that guide how organs should be allocated. And as you see there highlighted in point number 5, it must promote patient access to transplantation. And I think we all agree that that is a very laudable principle that we must accomplish. what I didn't anticipate in the beginning of my career was where the histocompatibility community would come in when it comes to equity and allocation. And I think that takes the form of sensitization. When we manage patients, we understand that sensitization is such a critical determinant of equity, and allocation principles are built upon sensitization. And so for our community in the HLA field, cPRA is really the driving factor that influences both allocation and equity. So I think we recognize from the outset, we have to make sure cPRA calculation is as accurate as possible, because if it's not, then we're going to introduce issues when it comes to inequity. I'm not sure if everyone's familiar with cPRA, but I do want to go back to the beginning and talk a little bit about the evolution of this metric. Back in 1960s, when transplant was in its infancy, there was this new idea that came about as PRA. And at the time, this was a lab-based method, really using a panel of local blood donors to represent the composition of the HLA in the local area. So back then at the time, the physician wanted to be able to tell their patients, and also for allocation purposes, knowing what is the likelihood that this patient can receive a compatible offer. Those of us that have been in the field for a long time remember these Terasaki trays. And basically the way that would work is you would take lymphocytes from around 50 to 100 healthy volunteers, primarily lab members or friends that we know, and dot them on this Terasaki tray. Then we take the patient's serum. And then we're looking for reactions, so if patients have a positive reaction, that would indicate that, those donors are not compatible. And from this little tray, you can calculate what's the probability in the donor pool that this candidate is not compatible with. So that's where the PRA metric came about. But as you can see, because of that, the PRA vary widely based on the location. They were using volunteer donors at a time. So if you have a different set of ethnic patients from different geography, then the composition representation would be different. And the method of testing was very heterogeneous as well, too. You can imagine that people had different techniques, the temperature might be different, the technique of washing might be different, that can influence the results. So then people realized very quickly, based on PRA, it's not a very good way to allocate organs. So things changed dramatically around 2010. And that's where the cPRA metric was invented. And that was coupled to one innovation, which is the solid phase assay, because for the first time, in the HLA field, we don't have to mix patient blood with donor lymphocytes anymore. We can simply detect antibodies, anti-HLA antibodies on solid phase assay, such as a single antigen test. And based on that, we can say then, what's the HLA frequency in the deceased donor population, and then calculate, based on the listed unacceptable antigens, what is the cPRA of that patient. Importantly, at that time, the frequency of antigens represented was A, B, DR, and DQ. As you'll see later, that is going to be a problem in terms of equity. And that was based on deceased donor cohort of 1 year from 2003 to 2004. Eventually, HLA-C locus was added to the cPRA algorithm, and that was updated to the 2008 reference cohort. So at this point in time in Canada, we didn't really have a Canadian cPRA calculator at the time. And I just want to point out and recognize the contribution of the Canadian innovators in this area. And what they found at the time was that the cPRA increases with DQ alpha, DP alpha, and DP beta as well too. And what do I mean by this? So if I go back one more slide, at the time in the UNOS calculator in the United States, they only consider antibodies to HLA-A, B, DR, and DQ. But if someone has antibody to DP, but the calculator doesn't account for it, then those antibodies are not contributing to their cPRA. And so that's what this publication showed. If I walk you through the different panels here, if someone has antibodies to DQ alpha, their cPRA would be represented 0% because the calculator didn't include the DQ alpha antigens. But if they were accounted for, their PRA could be as high as close to 100%. Similarly for DP beta as well too, if patients had DP antibodies, but they're not part of the cPRA calculator, then those patients are being disadvantaged, that their sensitization is basically not being captured. And so this publication nicely showed that amongst the highly sensitized patients is what it showed next. is that if patients are 98% to 100%, the majority of them have antibodies to DQ alpha, DP alpha, and DP beta, as well as allele-specific antibodies. So I hope that gives you a flavor that cPRA is not a fixed metric. It has been a metric that has been in evolution. In fact, the first iteration wasn't very good. And with repeated iteration, more of these loci are added, and then the metric became more accurate. So if we fast forward to the year 2022, which is last year, at the time in the United States, the cPRA calculator still did not include DQ alpha antibodies, DP alpha, and DP beta, as well as allelic antibodies. So just for fun, my friend Lauren Greger put in at the time an antibody to A0201, which we know is present in 47% of the population. At the time, the cPRA calculator still returned a value of 0%. So for that patient who has this allele-specific antibody, that is not being captured, that is not being measured. So then my friend Lauren Greger from Tulane University said, you know what, I'm gonna fix all these problems. He's a very smart bioinformatician who has HLA experience. And he said, you know, I'm gonna include now DQ alpha, DP beta, DP alpha, allelic antibodies, and this is gonna be the perfect cPRA calculator. And in fact, this has now been implemented in the United States. So then what happened afterwards? As the cPRA metric became better, what happened next in the United States was that they started to allocate based on sensitization. You might remember once upon a time when the PRA was less than 80%, these patients had 0 points. But as the PRA went to 80% or higher, they did receive 4 additional points so that they get some sort of priority for their sensitization disadvantage. But it was recognized that this is not very good because anywhere between 80 to 100%, the access to transplant is very different, and they all receive the same 4 points. That's pre-2014. So with the 2014 kidney allocation system being introduced, they introduced this sliding scale, such that this is supposed to compensate for the biologic disadvantage due to sensitization. Now, patients close to 100%, they will get 202 points to account for their disadvantage. And this system worked very well. As a matter of fact, this is a publication from Darren Stewart. He introduces metric called access to transplant score as a metric to measure equity. And what he found was that since the implementation of CAT system, kidney allocation system in 2014, in fact, the equity improved dramatically when they couple cPRA to the sliding scale system. So let me just summarize then, what did we discuss so far? The PRA initially started as a laboratory test to estimate the likelihood of finding a cross-match compatible donor. This is, back in the 1960s. And over time, the field came out with cPRA metric, which is now used as surrogate for patients' access to transplant. And accordingly, allocation policies now assign priority for patients with higher cPRA values. In the United States, they have the sliding scale. And in Canada, we have the highly sensitized program. So in Canada, the way it works is that anyone who has a cPRA of 95% or higher as a kidney patient, they get access to organs across the country. And that is meant to help offset their biologic disadvantage due to anti-HLA antibodies. So about 3 years ago, I did a thought experiment. I said, well, is cPRA truly a measure of global immune compatibility? And it seems like everybody believes that it is fairly good, especially after accounting for the DP alpha and DP beta and DQ alpha. But then I thought that, well, immune compatibility, one of the first principles is that it has to be HLA, but then also ABO compatible as well too. So it seems a little odd that our cPRA metric doesn't account for ABO. It only talks about HLA antibodies. And then I thought, well, did our field get it wrong the whole time? That how did we get to this state where we have a cPRA metric solely based on anti-HLA antibodies, but then we don't talk about ABO at all, when in practice, we know ABO is the first thing that we think about. So I said, I must have gotten this wrong myself. Someone along the way must have thought about this. I need to check with someone who's been in the field for a long time. So Paul Young, you will know this gentleman very well in the transplant field. He's been a great mentor to me. And I asked Paul, I said, Paul, tell me that there's a reason why the cPRA metric does not account for ABO. And he said, you know what, I don't know why, but it just evolved the way it did. It's a good question, but I don't have an answer for you. But then he said, I've been out of transplant for a few years now. You should talk to someone who's still in the field. So then I talked to my friend John Gill, who was a great mentor to me and obviously very active still. And John says, you know what, I never thought about things this way. But you know what, I'm not a HOA kind of person. You should talk to my friend Howie Gable. And I talked to Howie Gable, and Howie said, I think you're onto something here, James, because you're absolutely right. And I don't know why we never thought about ABO and HOA on the same scale, but this is something that you might be able to do. But you're going to need a friend to help you, because Howie knew that I don't have a bioinformatics background. And that's how I got introduced to Lauren Greger, who immediately understood what I was trying to say and said, you know what, I can help you with this project. We ended up getting linked to Darren Stewart, who previously worked with UNOS and did a lot of modeling work with the allocation, and now works at NYU. So I just want to recognize that this work was guided by the support of all these mentors that really have been in the field for a long time, and then saw something about this project that they felt was unexplored. So then the question is, how can we now address ABO disparity in allocation? How do we perfect the cPRA metric as we understand it to be? We thought that we might want to treat anti-ABO antibodies the same way as we do with anti-HOA antibodies. And then we can award allocation points and priority the same way that we do today for anti-HOA sensitization. So we coined this term ABO justice cPRA. What is this concept? So if I show you a schematic over here, here is a patient who is blood group O, who has a single antibody to DR53. And in the donor pool, there are 100 different dots here. So currently, this person's cPRA is 50% because DR53 is represented in 50% of the population. So if we punch in DR53 into the calculator, their PRA would be 53%. But then that assumes that this candidate has access to the other 50% of the donor pool. That is in fact not true, because this patient's blood group O. So in the remaining donor fraction, there's 26% of the donor pool that are ABO incompatible. So the true access to transplant for this patient is essentially the cPRA 50% plus the ABO contribution that's incompatible with 26%, and their ABO adjusted cPRA will be 76%. So Lauren then quickly wrote a equation for this, essentially taking into account the patient's cPRA by HOA, and then we have an adjustment factor for ABO, depending on the phenotype frequency of ABO in a population. And this is the paper that was published last year that described our methods in more details. But then what we did was we applied this concept of ABO adjustment to close to 200,000 candidates waitlisted in the United States. And what you can see right away is that there is a great difference in the ABO distribution amongst different ethnic groups. If I look at blood group B, for instance, in the Caucasians, we're talking about 10%. But if we were looking at African Americans, then that would be double that at 20%. Amongst Asians, which is very high proportion in Vancouver, we're talking about 27%. And so there's definitely a ethnic predilection for ABO blood group. If we look at the frequency of incompatible by ABO phenotypes, and this is very obvious to everyone, if someone is blood group AB as a candidate, they are compatible with every person by blood type. But if they're blood group O, obviously they can only get it from a blood group O donor. And the frequency of incompatible donor ABO phenotype is already at 52%. So the concept is fairly straightforward. So what we did next was to recalculate the ABO adjusted cPRA for all the waitlisted patients and see what would happen to them. And there's no surprise that when we did this, we found that a lot of the patients, their cPRA, when combined together, went much higher. For instance, for patients who are currently in the 99% category, if we're to consider their APO, close to half of them will move to 100%, and so on and so forth when you go down the scale. This magnitude of adjustment depends on two things. Depends on the baseline cPRA. So if someone was starting at 0%, obviously they have a higher magnitude to go up to than someone who's starting at 99%. And also the candidates blood group as well too. As pointed out earlier, blood group O candidates as well as B, they would have a higher magnitude of adjustment compared to someone who's blood group A. The AB patients, they don't have any adjustment. So how would that look like in kidney allocation? So then we went to the United States and we focused on the highly sensitized patients, particularly patients who are 99 to 100%. So if we take everybody who is 99.25% by conventional cPRA calculation, but then we stratify by their blood group, then we see that the majority of blood group B candidates and all the blood group O candidates, they really cross this boundary of 99.5. They should be counted as 100%. And why that's important is because when patients are 100% in the United States, they have a higher priority for broader geographic sharing compared to someone who is still at 99%. So there are these artificial boundaries that are made in organ allocation. So it does matter for us to capture cPRA as accurately as we can. So at this point, we wanted to provide more details on what is the practical impact of ABO adjustment on kidney allocation. It's nice to come up with a theoretical metric, but then I think what people would like to know is if you were to apply this metric, how can you actually affect allocation to better the access for patients who are currently under disadvantage? So there we came into an interesting observation, and I didn't really appreciate this at the time. So in kidney allocation in the United States, they're actually quite different from in Canada. In the United States, they allocate by ABO identical. What I mean is that blood group A candidates, they primarily get it from blood group A donors, the same for all the blood groups. But in Canada, once you go into the highly sensitized program for organ sharing across the country, we don't do it that way. We go by ABO compatible. So someone who is blood group AB can have access to all the blood group donors in the country. And when we realized this, we thought that it would be best to model this concept in Canada first, because there we would expect to see greater inequity because of the disparity between the patient and the donor blood group. What do I mean by this? So currently, if we have an AB candidate who's 99%, they can get access to all the different blood group donors. Compare that to a 99% blood group O candidate, they can only get it from a blood group O donor. So right away, you see the donor pool is quite different for both patients who are 99%. So in an allocation, what can happen is the following. If you have an AB candidate, their cPRA is 99% by conventional cPRA. It's going to trump this B candidate whose CPR is 97%, even though if you adjust for ABO, this B candidate is actually more difficult to match. So by current allocation, this kidney, this donor organ, would go to this AB candidate. And this B candidate, who is much harder to match, would not get access to that organ. And we worry that that's actually, in fact, what's going on. And we wanted to show, if possible, that if we were to allocate by ABO adjusted cPRA, we can take care of this problem. To do this, I want to thank Mike Gillespie from Canadian Blood Services and Rob Lusky from Dalhousie for the next set of modeling exercise that we did. And we wanted to model, if we to apply this ABO adjustment to transplantation in Canada, what would happen to this inequity? So the study aim was to, again, assess for potential access disparity due to candidate ABO blood group in the Canadian highly sensitized program. And we hypothesized that the current HSP policy does not account for ABO. It's going to lead to inequity. But if we were to apply this metric, now we can resolve this. The first thing that we did was to recalculate the cPRA of all the candidates on the waitlist in Canada. And we saw the same thing as we did in the United States. And then we wanted to model this disparity in 3 different ways. And the first method I would describe is called a static model. The second method is the time to offer. And then the last one is called a discrete event simulation. So what is a static model? The static model is very simply for us to look back over the past 10 years, what is the probability for someone to have an offer? So currently, in the HSP, over all these years, we've accumulated over 10,000 candidates. And so we asked the question, if someone's 95% cPRA, if you look back over the past 10 years, we should be able to find 5% of the donor pool that match them. And is that in fact true? And here is the result. And what we saw, just to orient you, this is the cPRA by conventional metric. And when we look back, we calculate the proportion of immune compatible donors. So for someone who's 95%, we are expecting them to match 5% overall of all the donors over the past 10 years. And that's only true for the AB candidates. In fact, when you look at the breakdown of the candidate blood group by ABO, those who are blood group O, they have only half of the matchability compared to someone who is blood group AB. And that shows very nicely in this Poisson model here. And then we say, okay, well, so there is an inequity that exists here. But what if we were to reassign patients by their ABO adjustment cPRA? What would happen? Then all the lines even up, essentially. That if they're 95% by ABO adjusted cPRA, they're going to match exactly 5% of the donor pool over the past 10 years. Well, the next model that we did was the time to match offer. So we started with an active wait list of candidates in the Canadian Transplant Registry in January 2018. So the way this would work is we have all these candidates lined up, and then the donors, we let them come into the model the way they did in actual life. Then we ask the question, what is the time it would take for this candidate to match every donor that came through this exercise? And from there, we can compute what's the estimated time to a match offer. And what we found was that for patients from the result actually shows all the way down to 95%, but for today, we'll show the results of 98 to 100%, was that the time to matchability for these candidates actually did differ by the blood group. Those who are blood group O and B, you can see, they would take the longest time to match compared to someone who is blood group A or AB. They had a faster time too. Now, this is a bit of a surprise to me to even show this difference, because we know that at 98% in our HSP program, they actually have a fairly easy time to match. But as you look across the board to 99 and 100%, where access becomes a real problem, those patients that can match somebody, the time it would take is much longer for blood group O candidates compared to B, and then followed by the AB candidates. The problem with our model is that that assumes transplant is a fixed box, but that is not the reality. The reality is that patients match, they come off the wait list, and then we have new people who are highly sensitized, they get added to the wait list as well too. So to mimic real life, what would happen, we did a discrete event simulation. And this one again begins with an active wait list of 2018. And then we just allocated a kidney as per standard fashion by our HSP policy. And when the top ranked candidates matched, they're removed from the wait list. And then the new candidates who are highly sensitized, they got added to the wait list. And this is probably as good as we can approximate what would happen in real life. The time to match offer was then recorded. And when we did the simulation, what we found was that by using conventional cPRA to allocate for patients who are 100%, we found that those who are blood group O, they have the lowest access to transplant. And blood group AB, they had the highest access to transplantation. And that disparity really lay out nicely as the way we predicted based on the phenotype representation of ABO in the donor pool. When we did the simulation based on ABO adjusted cPRA, we found that difference in inequity went away, that these lines, they merged together. Now, if you take a look, something very interesting happened here and unexpected. Now, these are the AB candidates. Well, why would they have lower access to transplant compared to the other blood group? And we had to think about this for a while. And what we thought was that this is an interesting phenomenon that shows the consequence of ABO disparity. So let me back up. The highly sensitized program was introduced in 2013. but we couldn't start a simulation until 2018 because the data elements required were not available prior to 2018. So between 2013 to 2018, we hypothesized that these AB candidates, because they have the best opportunity to get transplanted, they got transplanted, they're removed from the wait list. When we look at 100% category, we know there's a gradation. That's 99.5% all the way to 100.0%. So we feel that these AB candidates who are remaining on the wait list in 2018, these are essentially all the 99.99% candidates who don't have an ABO problem, but they have an HLA problem, that there's a preferential accumulation of the unmatchable patients essentially in this blood group. So then we did another analysis. We excluded these 99.95 candidates that we think are preferentially accumulating in the AB blood group. And when we did that, we saw that all the lines, they came together. The last modeling that we did was we wanted to ask the question, if we were to apply ABO-adjusted cPRA to the highly sensitized program, what would happen to the entire HSP pool as a whole? Are we going to cause issues? Are we going to cause some imbalance in a way? And the model shows this is a very unexpected result for us. And to walk you through this, if we were to reallocate organs just by conventional cPRA, at the end of 2 years, overall, we're talking about a matchability of 28% for this entire group of candidates. But if we were to match by ABO-adjusted cPRA, we found that actually 35% of the highly sensitized patients in the program would actually get matched. And we think that's because the efficiency of the allocation is improved when the truly most difficult to match candidates are receiving the offers first. So in the first example, as I described, I feel that when we look at the allocation sequence, the truly difficult to match once in a lifetime candidate, if they miss that kidney offer, they're probably not going to get it again. However, the much easier to match candidates, they will get a second shot as long as they are still on the wait list. So we think that by rejigging this puzzle here for kidney allocation, and we offer candidates who are the most difficult to match first, get them off the list, the easier to match candidates, they will get another shot, and they will also come off the wait list. We think that's the reason why overall 35% versus 28%, there's an improvement. So in addition to there's access inequity for patients who are 95% to 100% because of the ABO, we also want to look at patients who currently should be considered highly sensitized, and yet they're not. And so we do have this artificial boundary of 95%, after which you're now highly sensitized. But what about patients who are 85% to 94%? And I do want to point out that a lot of these patients, when you account for ABO, they should really be making it into the HSP, but they currently are not. And this preferentially affects blood group B and blood group O candidates. So when we put all this data together and we're thinking about, well, how should we allocate kidneys to ensure there's equity? We came up with this box, and this is actually what's occurring, and that there's a difference between the United States and the Canadian system. So in Canada currently, I think our forefathers got it right, that we went for the ABO compatible allocation. The benefit of that approach is it maximizes transplant opportunities. But if we don't account for ABO, we ignore the ABO adjustment, we're going to lead to higher ABO disparity. In the United States, they went the other way. They basically went for ABO identical allocation. So the issue with that is they were going to have missed opportunities when you can cross blood group and still get someone transplanted. But the benefit of that approach is, ironically, the ABO disparity is somewhat attenuated because of the policy restriction. But that's not ideal as well. The proposed ideal system is that maybe if we can do APO compatible allocation with ABO adjustment, then we have the opportunity to reduce disparity and maximize the transplant opportunities for these highly sensitized patients. So when I presented this work about a year ago, someone asked me, well, why don't we just allocate by the United States? Because then if you go by ABO identical allocation, you're not going to have the inequity issue that we currently have in Canada. But then I said, well, you're not going to be having the same transplant access as we currently enjoy. And I wanted to show that data. And I thank CVS for providing this simulation that actually effectively showed that. If we were to do the discrete event simulation, looking at the 3 possible ways of allocation, and currently in Canada, we're doing this ABO compatible, but we don't use ABO adjusted cPRA. This is conventional cPRA. We're in the middle here. If we went to what the United States is doing by ABO identical and also using conventional cPRA, the overall transplant access is going to be lower than what we currently have. So I believe rather than going that way, we should be thinking as a community to go into the future by introducing ABO adjusted cPRA, by sticking to the ABO compatible allocation. And I think that will take care of the inequity issue while maintaining transplant access and actually improve that. So a lot of people contributed to this, and we had the opportunity to share this work. What is the next step of what we want to do here? Outside of the highly sensitized program, we feel that this is going to have an impact on the kidney pair donation program as well too, because a lot of patients, they go into KPD because of blood group incompatibility. And there's a score that they get based on a number of factors. cPRA is one of those things that gives someone priority in KPD. And we feel that unless the cPRA calculator accounts for ABO, that will continue to be an issue. When we discuss with the thoracic transplanters, they also feel that they have probably inequity in the allocation of heart, lungs, and even potentially pancreas. So they are interested in modeling this work of ABO adjustment in their cPRA. We wanted to continue to work with the United States on their policy as well too, is that at the end of the day, they have a large country with a very heterogeneous ethnic makeup. And so we want to continue to shape the allocation policy in the United States. One thing I wanted to model, which I haven't been able to do using Canadian data, is the ethnic disparity. We know there's a tight linkage between ABO distribution and the ethnic blood groups, ethnic minorities. In the United States, they have the African Americans. In Canada, we have a lot of indigenous population. And ICO don't have clarity on, is there ethnic disparity if we don't change to ABO adjustment, and how can we best demonstrate that? When I present this work to different audience, people also ask me about geography as well too. And as we know, in Canada, we allocate organs primarily provincially, unless they're highly sensitized. And each geography in Vancouver, the population of donors is quite different from the population of donors somewhere else in the country as well too. So we're interested in coming up with a geography-specific ABO adjusted cPRA that's tailor-made for the region of the organs. After we published this work, I was really happy to see that this concept is kind of being examined in other areas as well too. This is a group in Hong Kong, which essentially applied this concept to their population and show that there's indeed inequity where they are, and that this could be a method to look at for resolving that issue. So there I conclude kind of the work that we did with cPRA adjustment. But I also want to point out that there's other factors that lead to inequity in transplantation. And one of them is the precision of antibody detection. Unless one works in the HLA community, it's hard to appreciate how hard it is to decipher what's a real antibody versus a fake antibody or a spurious antibody. And this is something that always bothers our field, because the assay, the single antigen test that we use to measure and to capture antibodies is not very accurate. And so, for instance, this is a project funded by the Kidney Foundation that we examine patients who basically have no history of sensitization, and yet they have detectable antibodies. And we found that they could be clustered into distinct patterns. These are patients who are males, never had blood transfusions before, and yet we're detecting antibodies. Now, they contribute to cPRA and their access to transplant, but what do they mean clinically? and we don't quite understand that yet. So again, unless we can improve the precision of antibody detection, they're going to contribute to inequity as well. And Dr. Rob Luski came up with this method to really test the significance of the spurious antibody. And I think this assay will go a long ways to help decipher who has spurious antibodies that contribute to cPRA and inequity, and how can we resolve those antibodies going forward. But I think the next frontier for our community is the ABO incompatible transplant. At the end of the day, we're not creating new kidney organs. We're simply designing a better metric that can ensure organs are allocated fairly. But we're not making up new organs for these patients. And I think for these candidates who really make a major difference, we have to think about how do we cross the blood group safely for our candidates. And there I have the pictures of my close colleagues who are working on improving that for our community. Dr. Lori West and Halpin and Rob Luski are really innovators in coming up with ways to measure these anti-ABO antibodies and characterize their pathogenicity to inform which are the anti-ABO antibodies that we can cross safely. And Dr. Christopher Guan at UBC, who is a kidney transplant surgeon working with Peter Raphael and Stephen Withers, are pioneers in applying these ABO enzymes that can convert blood group to ensure there is a healthy compatible donor pool for patients who are blood group B and blood group incompatible. So to sum up, these are basically the different ways we can allocate organs. I don't think we want to allocate based on equality. Equality is basically treating all these candidates the same, irrespective of their sensitization. I think we have to recognize that some of these candidates, this is no fault of anybody. They have this biologic disadvantage, and the goal of the kidney allocation system is really to offset that disadvantage. And I hope that the data shown today can spur this discussion on, well, ABO is really a major barrier still. And unless our yardstick to measure that disadvantage is accurate, these patients are going to be in a hole. They're really facing the brunt of this inequity and never get priority for that. And so we have the tools now to help offset this disadvantage. And I think our community hopefully will adopt this metric and change that in the near future. The conclusion is that the current Canadian ABO compatible kidney allocation approach, it's good because it maximizes transplant opportunity for highly sensitized patients. But without consideration of ABO incompatibility, the blood group B and O candidates are going to be under-recognized for their reduced access. And the implementation of this metric has the opportunity to improve both the equity and efficiency of kidney allocation. So I want to acknowledge Lauren Greger, again, who was my partner in crime in designing this metric and calculating computationally, which is very challenging for the close to 200,000 candidates in the United States. The UBC kidney transplant program, the UBC pathology and lab medicine program, and really a lot of synergy with Canadian Blood Services that performed the simulation for the whole country and really supported this work for the past 2 years. The external collaborators, Howie Gable from Emory University, and also from UNOS as well. I also want to thank the National HOA Advisory Committee for supporting this work and providing a lot of really good feedback as we shape the development of this work.
Thank you, Dr. Lan. Very important work and, as usual, an amazing presentation. I would like to open the forum for questions. As Saide has mentioned here, either raise your hands or post your questions in the chat box. See one.
James, I just want to say a big thank you for your recognition of Mike Gillespie in particular. He's one of the unsung heroes, I think, in Canadian transplantation. He asked a question in a meeting back in 2009, and it still sits in the National cPRA calculator to this day. Well, why wouldn't we include ABO in our cPRA calculator? And it still sits there. It's not the exact same methodology as is used today, but I mean, the response back was essentially, well, we just don't. But you've really proven that his curiosity was onto something at the time. My question is, in the HSP system, I remember there was a discussion a couple of years ago about your work and whether it might remove the need for the O to O matching, because O to O was kind of built into the hierarchy of the HSP ranking as kind of a very basic equity prioritization. Does this work remove that need?
Absolutely. So I think even back in the days, it was somehow recognized that, wait a minute, all these blood group O donors are going into other people, so we should try to save some of them for the blood group O candidates as well. So to me, that was a crude way to make sure we don't lose too many O's to the other blood group. If the community adopts this metric, then that would go away. I would view in the future in an ABO compatible system that every person would have one metric, and that metric really accounts for the ABO effect, and there's no need to go the O2O kind of route anymore. So I really hope to break down that barrier. There's HLA, there's ABO, that we can one day look at the patient to say, this is your sensitization, period, and then we can now allocate accordingly based on that, rather than to say, okay, you're A, you're B, and then you're O. I think that just creates more boundaries and barriers.
Agreed. That's great to hear.
Thank you. Any other questions? Okay. While others are coming up, I can ask one question. So, the concluding slide, that point about geographical inequality is such an interesting thing, James. Any idea in the National HSP program if province of BC or Ontario, where there is a huge ethnic difference, has been more disadvantaged compared to when we see the data overall at the national level?
Faisal, thank you for that question. And the only thing shocking to me is that we cannot characterize ethnic disparity in Canada right now. And I wanted to model this out to look at disparity using what Mike GLC did with the HSP program. And he couldn't really do that because close to 40% of the candidates and their donors do not have a data field populated for ethnicity. And so that is going to be a problem, because how can we say that we want to improve inequity when we don't have that data to begin with and we have no way to measure that, And so I think we have to start this process where we actually do routinely capture this, as it's such a critical information that if we don't have it, we cannot have an equitable allocation system, And so for the next project, I'm actually going back to the United States because their stuff is captured. We can say a lot of things about what's good about in Canada, but they do actually have ethnicity data captured in patients and donors to allow this kind of modeling to occur. And what we're hoping to see, because ethnic disparity is very complicated. In addition to just purely access to transplant, there's many reasons why certain ethnic populations, they have disparity. All the way from, are they referred timely to transplantation? Are they activated soon enough? When they're on hold, do they get back to the wait list as quickly as other patient blood groups, patient populations? And so they really face a lot of barriers, some of these blood group, these ethnic minorities. And so I think this is only one factor, and we do have to start to capture that now in Canada if we want to make a real difference.
Makes sense, James. I have Anne raising her hand. Please, go ahead.
Hi, James. That was an awesome talk as always. I always every time I hear you speak about this, more questions pop into my mind. And I couldn't agree more about, why aren't we capturing this information for our Canadian populations? So important. And I know Abir Mabdouli did a great also ASHI podcast and ASHI quarterly article about defining race, ethnicity, ancestry, and I actually hadn't really thought about those definitions either. I'm not quite sure actually how they apply to ABO, and maybe ancestry, I guess. I don't know. I'll have to think about, maybe you have thoughts on that. But my question is about ABO A2 allocation, which is coming some stage to the KPD program. I'm not a member of KTAC. I don't ever attend those conversations. Maybe you are. Is that something, do you think, could also eventually be part for like low titer, low anti-A2, A subtype 2 individuals and with low antibodies could be allocated within other systems? How would that affect, do you think, an ABO corrected cPRA? What are your thoughts on that?
Yeah, that's a very interesting question and a very good one too. The way I see it is that if we didn't have a blood group problem, if every donor is universal, then we don't have the need for ABO adjusted cPRA is gone. This metric is not necessary anymore, And so as we start to cross blood group more, and we feel that is safe, then that has to be accounted for, because all of a sudden that A2 donor is now going to be treated effectively as a blood group O for some of the patients that have low titers, And so if you want to be completely accurate, then we have to account for that as well too, So then you can imagine for some of the patients that have very low anti-A2 titers, then their ABO adjusted cPRA metric would be different than others that have the high titer. Then that becomes very sophisticated. But that is a good problem to have. And again, I echo what you're saying is that ABO incompatible transplant is very underutilized in our country. And that I'm very happy to work with you and others that there is a interest to kind of jumpstart this program again, both in the national KPD setting and also intra-provincially as well too, for sure. One of the things about geography that's interesting is when we presented this work, different countries, and I think we're lucky in Canada, I just always assumed that the cPRA calculator was always there, and then not knowing that our forefathers had to invent that and actually build it. And when you talk to other countries, there are many that don't have their own cPRA calculator and they want to build one. They might be trying to use the Eurotransplant or the UK or the Canadian one. But they would like to have their own as well too, So we've been getting requests to help them build a calculator. And then, so Rob Lusky and I were discussing, so why don't we come up with a way, just make it free for all, a worldwide calculator for cPRA with ABO adjustment, and whereby you just have to put in the population frequency of ABO and HOA in the donor into the data set. And then there you go, you have your own tailor-made a calculator for your own region, And so we're kind of developing the idea a bit more, but if that could be done, that could be open access kind of a tool for everybody to use, right? You just import your data set and then there you go, boom. And you can adjust it any way you like. Maybe you don't like the ABO adjustment so much, you don't want that, that's okay. But you like some aspects of the calculator.
Yeah, that's great. And maybe even ABO A2 could be built into something like that, because that's really low in a donor population, say in Asia, as compared to North America. So it's not a useful tool or approach or, potential strategy for some parts of the world, whereas in other parts of the world it is. So yeah,
you're absolutely right. Yeah, you're absolutely right.
James, I have a question in the chat box. Sarah is asking, do you have any thoughts on patients with mixed ethnicity?
So the ABO adjustment really just takes into account of the candidate blood group. But the mixed ethnicity, the disparity for patients with mixed ethnicity, I think that's something that's not well characterized, is what I would say. Because for mixed background, their HOA composition will be a little different from the usual. And so they probably will face more of an HOA barrier as well if you're highly sensitized and you add in the ABO issue. So I think that part is unexplored. And I'm really interested in the ethnic disparity question, as I said before. And if we can even get a couple centers together that are interested in this, because every center has their own ethnicity data, although it's not in CTR, that we can probably do some analysis to model this out.
Dr. Mustafa.
Hi, thanks, James, for this nice presentation. And as Anne mentioned, every time I hear it, I have more questions as well. So I know that you have shown in one of the earlier slides that in the organ allocation in Canada, like all blood groups gives to AB, but the frequency of AB blood group is not that high in Canada. It's like, I think it's like 2% of the population are AB. And the other thing is also, it's not only AB that takes from O, it's A and B as well. But we never give a different blood group unless we cannot find a suitable match for the O. So I don't want to accuse that A or B or AB are taking from O, because usually we match at the O level first or at the ABO group first, and then if we couldn't, then we proceed to the next level, which is A, B, and AB. So I don't know how much, when you did your statistics, put this into your consideration.
Yeah, so you're right. So if you have two patients who are both 100%, the O donor will go to the O patient first. However, if you have a patient, let's say who is blood group B, and they're 97%, sorry, like they're let's say blood group B who's 99%, and another patient is blood group O who's lower down, then it's not being type broken by the O to O anymore. It's being type broken by the cPRA first.
Mm-hmm.
And so that is effectively the issue, is that it's broken by cPRA first and then broken by the O to O blood group. So if the cPRA has an issue because it's not capturing that magnitude adjustment, then you don't even see the offer in the first place.
Okay.
And so the O to O rule in there is actually very good to ensure, at least when you have the same cPRA to begin with, you're giving to the O candidates first and not by some other factor like dialysis wait time or something else. But then that's only if you're starting with the same cPRA. But if another candidate, a different blood group, you know, AB or A or B, is starting off at the higher cPRA, then they're going to get that one first. That's the issue. Yeah.
Okay. Thank you.
Okay, I don't see any other questions. Thank you, everyone, for attending, and thank you, James, once again. What a brilliant work, and such an important piece of work that we need to know in Canada.